Okay, this is chapter 13. Let me share my screen and we will get this up. All right, we're going to talk about the altered immune response. There we go. Gotta love an apple when they do that. All right, so the altered immune response and transplantation, chapter 13. There are, let's see, there we go. The normal immune responses. Let's see if I can move this. Hold on. Let's put you down here. There we go. All right, so the normal immune response, the body is the body's ability to resist disease. There's three functions that it serves: the defense of things that might jump on. It provides homeostasis, and then it goes into surveillance mode to see what's out there. Okay. Types of immunity. We have innate, nonspecific responses. These are present at birth. They're neutrophils and monocytes, and we've already talked about some of this. They present a first line of defense against pathogens. Like I said, they're present at birth, and they start the acquired immunity. Acquired immunity is specific responses. Antigens are substances that the body recognizes as a foreign, and it elicits an immune response, and most of them are composed of protein. Antibodies are immunoglobulins produced by lymphocytes in response to antigens. So there are a couple of types of immunity. We have natural and artificial, and then we have active and passive of both. So a natural active is something that you've actually come in contact with the antigen. So, for example, I have a natural active immunity to chickenpox, measles, and mumps because when I was a kid, we didn't have vaccines for those. I bet most of you guys have an artificial active immunity for these guys because you have probably had the vaccine for chickenpox, measles, and mumps. Back on the natural side, we have passive immunity that happens between mom and newborn, and that's a transfer between transplacental and colostrum maternal immunoglobulins that are passed to the baby. Now, that's a short-term protection. It's not going to last for more than a couple of months. The same thing on the passive artificial side. The infection or injection of serum with antibodies from one person to another, like when you get a dose of immunoglobulin for hepatitis B, that lasts short term. So it's artificial, it's passive. It will keep you safe for a little bit, not forever. Let's look at the immune system. The organs of the immune system. We have tonsils, we have lymph nodes all over. We have the thymus gland. The bone marrow gets involved. We have genital association. We have the spleen. There's lymph tissue in the gut, also in the skin. And we have some bronchial associated lymph tissue. Let's go back to the spleen for a minute because what would happen if you had some kind of an accident where you had abdominal trauma and your spleen had to be removed? That might present a problem in the future with immune status. So keep that in mind. If you ever have a patient that has had a splenectomy, be aware that they might have some immune issues. All right, so this slide is probably going to look somewhat familiar, and this is in your book. And this is just a breakdown of macrophages and lymphocytes in the immune response. I'm going to let you take a peek at this and go over it in the book because we went over this last week. This is just the way the humoral immunity and the cell-mediated immunity respond to invaders. The next two slides are going to be a comparison of what humoral and cellular or cell-mediated immunities do, or what their components are. So in humoral, the cells involved are the B cells. In cellular, the cells involved are the T cells and the macrophages. The products involved in humoral are antibodies. In cellular, they're sensitized T cells and cytokines. Memory cells in humoral, they're present, and in cellular. For protection, the humoral system works against bacteria, viruses, extracellular, respiratory pathogens, and GI pathogens. In cellular, for protection, they work against funguses, viruses, intracellular viruses, chronic infection agents, and tumor cells. So let's talk about humoral immunity. Antigen antibody-mediated immunity. This is antibodies produced by plasma cells, and these are differentiated B cells. These primary immune response is evident in 4 to 8 days after the initial exposure to the antigen. So these are the workhorses. So when an individual is exposed to an antigen for a second time, the response is much faster. That's when the memory cells have kicked in and they know this song. They respond in 1 to 3 days, and they also last longer. So the main product of the secondary response is the IgG rather than the IgM. The memory cells account for more rapid production of the IgG, and there's a nice little chart here, this is in your book, that depicts the primary response. And on the primary response, the IgM kicks in first and starts fighting, and then the IgG is the memory cells that come in. Well, on the secondary response, the IgG says, hey, I recognize you, I know how to fight you, and it kicks in right away. That accounts for the quicker response. On the cell-mediated side, the immune response is initiated through specific antigen recognition by T cells. The important roles, the immunity against pathogens that survive inside the cells, and these are viruses and some bacteria, also fungal infections. This also is rejection of transplanted tissues and contact with hypersensitive reactions and tumor immunity. So here are some things, some effects of aging on the immune system. So we see an increase in incidences of tumors. We see greater susceptibility to infection. We see an increase in autoantibodies, a decrease in cell-mediated immunity. We see thymic involution. We see a delayed hypersensitivity reaction, a decrease in IL-1 and IL-2 synthesis, and a decrease in expression of IL-2 receptors. So we're decreasing less and we can receive less. That's a double whammy. A decrease in proliferation response of T and B cells, and a decrease in primary and secondary antibody responses. So there's 3 types of altered immune responses that we're going to talk about. We have a hypersensitivity reaction, and this is an overactive immune response against the foreign antigen. This is like a Chicken Little response. The sky is falling, the sky is falling. It's just an overreaction. I don't know why the body does it, but it does it. We also have autoimmunity, and this is an immune response against the self, which is an immune response that no longer differentiates self from other. It's like the body is attacking itself. And then just the very opposite of that, the immune system does not adequately protect. So let's talk about hypersensitivity reactions, and these are like IgE-mediated humoral immunities, and you've probably all had some of these: allergic rhinitis, asthma, anaphylactic reactions, and atopic reactions. This picture is a picture of an anaphylaxis reaction. I can't imagine what she's reacting to, maybe a bee sting or a food allergy. It looks like a pretty severe reaction. So let's talk about what you might do for this type of patient. The number one thing that you do for anaphylaxis is make sure that the patient has a patent airway. Be ready to intubate if you need to. Always have that crash cart right there, because all of your intubation equipment should be right there. If this is an insect sting, remove the stinger. You want to establish an IV access. And hopefully you've got several people working with you, so you're not alone with this. We're going to give epinephrine, 1 milligram per milliliter preparation, and we can give 0.3 to 0.5 milligrams IM preferably. Although if I've got an IV, I'm going to give it IV. And we're going to give that in the mid-outer thigh. And you can repeat that every 5 to 15 minutes. We're going to give high-flow oxygen, 8 to 10 liters per minute, and we'll give that via a face mask. And we can give up to 100% as needed. We're going to give nebulized albuterol for bronchospasms if this patient is resistant to epinephrine. We can give diphenhydramine, IM or IV, for urticaria and itching. And we can give corticosteroids like methylprednisolone or solumedrol. We're going to watch this patient for hypotension. We'll place him in a recumbent position and elevated legs. Recumbent is laying back. We might even need to go into a reverse Fowler's position. IV normal saline with a rapid bolus of 1 to 2 liters. We're going to maintain their blood pressure with fluids, volume expanders. We might even need to give them some vasopressors like dopamine. And then we'll monitor them. We're going to watch their vital signs. We're going to monitor their respiratory effort. We'll watch their O2 saturations. We'll evaluate their level of consciousness. We'll look at their cardiac rhythm and watch their urine output. Again, we anticipate intubation if there's severe respiratory distress, because we do not want to do a cricothyrotomy or a tracheostomy in the case of severe laryngeal edema. Have your crash cart nearby. All right, a little less dramatic, some atopic reactions, allergic rhinitis or hay fever. These can be seasonal or year-round. It targets mucous membranes of the upper respiratory tract and conjunctiva of the eyes. Symptoms include nasal discharge, sneezing, lacrimination, mucosal swelling of airway obstruction, and pruritus around the nose, eyes, throat, and mouth. You might also have someone come in with hives or urticaria. These are cutaneous reactions against systemic allergens with wheals that vary in size and shape, and they do vary in size and shape. And then angioedema, which are localized cutaneous lesions involving deeper layers of the skin and submucosa. Okay, assessment of chronic allergy interventions. When we do this, we look at a physical assessment and then we look at a bigger picture. We might do a diagnostic workup. We might do some skin testing. We look at a family history, maybe some social factors. We look at environmental factors, any kind of medications that they might be taking, and that would include prescription and over-the-counter. If we can identify the allergen, we will do that. We can do that with skin testing. We can also start eliminating things from the diet. We would look at things like stress management. We might teach relaxation techniques, discuss environmental control. If the patient has a drug allergy, they need to be wearing a medic alert bracelet. Make sure the drug allergies are listed on all medical and dental charts. And the patient needs to know how to use an EpiPen if this is an insect allergy. Drug therapies. So we use antihistamines. We use sympathomimetic drugs, decongestant drugs, corticosteroids, and antipruritic drugs to relieve the itch. We can also use immunotherapy, and those can be given subcutaneous and sublingual. We would look at doing a CBC. We would look at doing sputum and nasal secretions, pulmonary function tests in the case of asthma. We can do skin allergy testing, and your book talks about 3 different styles of that. And then we would also look for allergy blood testing for IgE, but this is being used less and less. It's kind of an expensive test. All right, so let's talk about latex allergy because this is a hot topic for healthcare workers. We work around a lot of items that have latex in it, and this list is pretty extensive. I'll let you read through it. But I also want to point out that latex food syndrome is something that you might need to look at with some patients, and that is a sensitivity to banana, avocado, chestnut, kiwi, tomato, water, chestnut, guava, hazelnut, potato, peach, grape, and apricot. If patients or people are sensitive to those foods, then they may have a sensitivity to latex. So be aware of that. I lost my cursor. There we go. Okay. So let's see. I got my slides off here. There we go. So we identify patients and healthcare workers with allergies, with the latex allergies. We do a complete history. We look at food allergies for the latex food syndrome, and then we provide a latex-free product cart for latex allergy patients and healthcare workers. All right, autoimmunity. This is an immune response against the self, in which the immune system no longer differentiates self from non-self. Age may play a role in this. This tends to happen as you age. It also may have a genetic predisposition. Table 1313 has examples of autoimmune diseases. Since this is in the slide presentation, I would highly recommend that you look at table 1313. I'm just saying. Organ transplantation. All right, this is the last couple of slides is going to be about organ transplantation. The human leukocyte antigen, HLA system, is used primarily for matching organs and tissues for transplantation. This is huge because this is how we keep from having organs rejected. This has really done a lot to keep rejection down. Figure 1311 in your book shows tissues and organs that can be transplanted. Transplants can come from deceased or living donors. You have heard of people that donate kidneys, livers, partial livers can be donated. Many of our donors are accident victims that are pronounced dead, brain dead, and then we retrieve organs in the OR and let the patient go ahead and die at that point. The testing of organs for transplantation is done through HLA typing, that's the human leukocyte antigen typing, through panel of reactive antibodies, and through cross-match. So we talk about transplant rejection, and there's a couple of types. Hyperacute rejection usually happens right away or within the first 24 hours. And the only alternative is to remove the transplanted organ. And sometimes the patient simply dies. Sometimes they just die if they have a severe reaction, that's possible. A lot of times they'll get the organ out and the organ is not salvageable. They're not going to be able to put that in anybody else. Hopefully that happens less and less because we're doing the matching better and better now. Acute rejection is to be expected. Every transplant patient can expect and should be educated they will have some form of rejection. The response to that is we will have additional anti-rejection drugs ready to give you. Don't fear it. It's going to happen. We're ready for it. Chronic rejection is also going to happen. A transplant patient is going to be on immunosuppressive therapy the rest of their life. If someone comes to you and says, hey, I'm about ready to get off of my immunosuppressive drugs, you better set them down and have a long talk with them, because that is a lifelong treatment for them. They will never come off of those immunosuppressive drugs. If they do, they will reject and die. Maybe they're at that point, they're telling you, hey, I'm going to die. But those are the 4 types of rejection that we typically talk about. There is one other type, that's the graft versus host disease, and that's where the actual transplanted organ tends to reject the body that it's placed in. That doesn't happen often, but it does happen. So that is the end of this chapter, chapter 13, and we'll get set up for the next chapter.